see my screen?
We can do both, Tari. Thank you.
Great. Okay. So I'm going to be presenting on a case we actually saw quite a while ago in the unit, very interesting one. So, okay, so 45-year-old female who presented initially to False Bay Hospital with a history of being short of breath and coughing for around 3 months. No other constitutional symptoms, and this is the chest X-ray that was there. Sorry about the quality, but there was a pleural. On ultrasound there was a pleural fluid, so they tapped it, and that showed an ADA of 57 and mononuclear cell predominant. Unfortunately, I don't have anything else on that. I don't have a protein or an LDH, but she was subsequently then discharged and given TB treatment. She then presents a week later, again back to False Bay Hospital, and over there they were concerned that she was looking very unwell and and clinically was had pericardial tamponade. But when they did an echo of the patient at the site, they saw that actually there was very little fluid around the heart. But late in the evening, they managed to send the patient across to cardiology, and cardiologists were great and got the cardiothoracics team involved, and they aspirated 200 mils of a straw-cluttered fluid. But that was actually taken, the patient actually taken to theatre at that point in time, and a pericardial window was done. And I'm going to get straight to the diagnosis. And I was called at around 10 o'clock in the morning saying, "Hi, Tari, I've got a case of a patient that there's schistosomiasis seen on a pericardial biopsy." And I said to the lady, I said, well, to the clinician, sorry, I said, "Are you very sure? You're not talking about another area?" She's like, "I promise you it's there." So I said to her, "Okay, come see the patient." And I thought to myself, let me just make sure. I've never heard of such a thing before. And indeed, here we go. And yeah, highlights schistosoma over, negative for acid fast bacilli, and the pericardium. There we go. The excision shows schistosomiasis, granulation tissue, and fat necrosis. So very interesting. Then we were like, well, now let's investigate this, because I still don't believe that this is schistosomiasis. What are the chances that it's in the pericardium and causing this pericardial effusion? And in the meantime, we still left her on TB treatment based on the chest X-ray and, cough for 3 months and shortness of breath. And interestingly, the serology came back on 2 separate occasions as negative for the Sucaria, and stool was sent off ×1 negative, and 2 urine samples were sent off between 10 a.m. and 2 p.m. And again, nothing observed, no schistosomiasis. So then we went back to the patient. By this stage, she's extubated. She was very unwell at the time, and actually also had a drip site infection. And if I remember, it was secondary to an MSSA or MRSA. I can't remember off the top of my head, but that's besides the point in this case. And then we went to her and we said to her, well, let's just take a bit of a travel history. Where have you been? What do you do? So her occupation is she works at a coffee shop, and nothing out of the ordinary. And but then said to us, she went on a pilgrimage to Israel, and that was in 2018, and she was baptized in the River Jordan. And for those that don't know exactly where that is, so this is Tiberias, and then here is the Dead Sea, and then the River Jordan bordering between Israel and Jordan over there. And then I called Prof. John Freen in Joburg saying, wow, I can't believe it. We've got a really interesting case. Have you ever heard of something like this? And we were discussing, and where's the patient from? I said, no, we think the patient got it from Israel, the River Jordan. He's like, no, can't be. There's no such thing. There's no schistosomiasis in Israel, not that he knew of. And then we were like, whoa, okay, hang on, let's go read a little bit more. And then there's a site that I highly recommend to people if they want to know a bit about infectious diseases in various countries. It's NAFNAC, And I went searching a little bit, and well, obviously Prof. was correct. And according to the WHO in 2012, we think that the interruption has stopped, and the risk is very low. So then we went a bit further, and I went back to him. I'm like, ma'am, you sure you haven't gone anywhere else? No, doc, I promise you. And then I was like, okay, when you were a child, did you ever go on school trips? Yes, we did. Where did you go? No, we went to the Eastern Cape. Oh, what did you do then? No, I think we walked through rivers and we swam in the dams and et cetera, et cetera. And I was like, oh, okay, well, maybe that's your exposure risk. And then we thought to ourselves, oh, fantastic. Okay, what an interesting case, lovely diagnosis. Still in the back of our heads, we're like, oh, but this is really unusual. Okay, but all right, let's give her some praziquantel. And we said we'd see her in 4 weeks' time at our ID clinic. And just before she was meant to, it was actually a comedy of errors, and she was meant to be discharged on a Friday, but didn't get her praziquantel on time. And cut the long story short, on Monday, she was still here, and she started complaining, I'm not feeling like a doctor. I'm very short of breath. And she was quite diaphoretic as well. We're like, oh, is this pericardial effusion coming up again? So then they did an echo on the patient, and no, the pericardium looks okay. And this is what the chest X-ray looked like. And I mean, you can see our suspicion. We were concerned that, yeah, there might be a pericardial effusion. But also if you look over here, where it's going into the right main bronchus, it looks like there's something sitting over here. And then, well, there's an effusion over here. Okay, let's just do a bit more investigation. And by now she's spontaneously gotten better. And we said, well, suddenly got short of breath, PE. So we sent her for a CT scan. And this is what the CT scan showed. And if you look over here, well, that's the heart. And then what is all of this? Maybe a little bit of an effusion over there, but what is this thick encasement? And essentially, in a nutshell, showed cardiac compression, superior vena cava and the left brachiocephalic vein were obstructed, and this mediastinal mass. So we're like, wow, clot thickens, now what? And then we asked our friendly radiologist, Quinita and her team to get involved and to take a biopsy of the area. And lo and behold, non-Hodgkin's lymphoma, high-grade B-cell lymphoma. And call our hematology colleagues, who then obviously are very helpful, and took over the management of the patient and started treatment on her. And we decided at that point in time, well, we got no evidence for TB, gene expert, all the rest are negative. Culture is still pending, but it's about 3 weeks in and nothing's grown. Okay, probably not related. And we've got a lymphoma already on biopsy. And sorry, she is HIV negative. I should have mentioned that earlier. And she gets R-CHOP, and she's been following up at the hematology E5 clinic ever since. And as far as I know, is doing quite well. So then I thought, well, let's just discuss a little bit about these uncommon manifestations of schistosomiasis and how that occurs. Not to bore anyone, but going to go through this pretty quickly. But these are the main schistosomiasis eggs that you get. So obviously, there are more than that. And that is Mansoni with the lateral terminal spike, and Japonicum, which is a tiny one, which you can't see, and then the hematobium, which is the terminal spike over there. And they get, when they hit the water, you get the myricydia, which release, and then the myricydia go and target their respective snails. And Mansoni goes for this one over here, which is your biofilariae, and then Japonicum goes for oncomelania, and then hematobium will attack bilineus over here. And then what happens, sporocysts are released, then Sarcoria then penetrate through the skin, and it loses its tail over there and makes schistosomiasis, and those then migrate to the various areas. For example, Mansoni will go sit in the inferior mesenteric veins, and then the hematobium generally goes to the fascicle plexus. and the female goes into the gynecophoral region of the male, and then they start to copulate and release all these eggs. Now, what are the manifestations that you can get? So what happens is you may get neuroschistosomiasis, and that is related to this aberrant migration of the adult worm to the brain or the spinal cord, with the eggs being released into that area. And what basically is it's related to is that you get your, for example, your inferior mesenteric veins, which then communicate with the spinal veins, and that is via Batson's plexus. And what happens is these eggs will start to travel into the spinal area and move up to the brain. And japonicum is more likely to move up to the brain, and that is related to the size of the japonicum being smaller than the Mansenii and the hematobium. And I'm sure you noticed that on one of the first slides where we showed the life cycle, whereas Mansenii and hematobium will go sit in the spinal cord and do their damage from there. Now, it's basically a Th1 response, which then changes to a Th2 immune response with granuloma formation. And there will be thousands of these granulomas because there's thousands of eggs in those regions, and that causes mass effect, and that gives you your intracerebral lesions, your myelopathy, and your myeloradiculopathy coming from there. And then if we look at pulmonary schistosomiasis, okay, so this is usually seen in late stage disease, and it's where patients have basically hepatosplenic schistosomiasis with associated portal hypertension. And then, as we know, when you get the development of this, you get shunts, your esophageal varices, etc. And then these eggs move along these shunts, and that causes vascular remodeling, and that's related to the eggs itself or the immune response, which we've already discussed, and that will then give pulmonary hypertension. Another one which I think is not really seen that often, or maybe we're just not looking for it, but it is something to consider, is aberrant migration of the eggs in the female genital tract. So in these cases, patients can present with schistosomiasis eggs in the uterus and at the cervical regions, and patients may complain of postcoital bleeding because it also affects the vasculature in the area, creating this postcoital bleeding, and then it may affect the fallopian tubes as well. And then also that is related to this vesicle due to the veins that are found in those areas where there's communication between the GIT or the urinary bladder. Okay, and then just to get back to the case itself, really not much in the literature, and I was quite happy to see that one of the first cases that was described was in 1979 by Ronald van der Horst, who basically described a 16-year-old female who presented with what looked like cardiac pericardial constriction and required a pericardiectomy. And the histology at that point in time showed a schistosomiasis hematobium, and the patient's urine also showed the same. And at that time, there was actually concomitant disseminated TB, which involved the pleural and the pulmonary areas. And another case potentially was also in Egypt. I can't remember the date. Oh, 1995, sorry. 1995 was this case over here. And basically, as we know, in Egypt, there's a lot of cases of schistosomiasis, and they looked for endomyocardial fibrosis, which they saw in 15 out of 10,000 patients who were infected with S. mansenii. And one of those 15 had schistosomal granuloma formation seen on endomyocardial biopsy. Then the next question I had is there any association with lymphoma or non-benign lesions and schistosomiasis. And not a lot of literature, but he has some case reports. And this was an 11-year-old male who had this hypogastric mass, which was excised and showed both Hodgkin's Reed Steinbug cells as well as Mansenii infection. Another case was a 15-year-old female with diffuse large B-cell lymphoma with concomitant hematobium in the mass itself. And then over here, what I wanted to discuss is, I was still very suspicious of this being schistosomiasis of the pericardium, and we chatted to the anatomical pathology team, and they were quite confident about their diagnosis, and we were quite grateful we were managed to actually get a PCR done of the pericardial tissue. Empath kindly helped us to do it in private, and that came back as positive. And unfortunately, they're not able to tell us whether it's a schistosomiasis Mansenii or hematobium. But I feel that with everything we've got so far, this is probably a case of schistosomiasis of the pericardium. And I'd just like to thank a few people, that's Empath and Dr. Fakir from the anatomical pathology unit, and Michael Boyd, who's also part of the conversation over here, who helped with a lot of the literature researching and helped us with history, and we saw the patient with him together. So thank you to everyone who helped.
Thanks very much, Tari. Lovely.